Thank you. So I'll talk briefly about latent tuberculosis. Uh, so this is mainly based on the national TB guideline, which is freely available on the net. So please feel free to look at that because this is not a very detailed presentation. So what is latent TB? It's the persistent immune response to stimulation by Mycobacterium tuberculosis antigens with no evidence of clinically manifest active TB. But to make it simpler, it is infection without disease. So out of those patients who have latent TB without treatment, 10% will go on to develop active TB during their lifetime. 5% of that 10% will be in the first 2 years after the infection. And afterwards, it's 0.1% per year. Now, not everyone infected with the TB bacteria develop illness. In latent TB, an immune response is indeed triggered within the body, usually within 2 to 8 weeks after the exposure. In these individuals, the TB bacteria are killed, contained, or encapsulated. So those contained and encapsulated bacteria are not really dead. So they are the ones who can go on to develop active TB later on. So latent TB is, I believe, a spectrum rather than a single entity, and sometimes the distinction between active TB and latent TB is not very clear. This is not from the national guideline. In the national guideline, there's a clear cutoff between latent TB and active TB. There are implications to this hypothesis. That is that there is a subpopulation within this group which currently defined as having latent TB who would be preferentially targeted for preventive therapy. Now also efforts to develop drugs for effective treatment of latent TB should overlap the search for drugs that would shorten the treatment times for active TB. So I think the most important thing that we should all remember is to exclude active TB before we try to diagnose latent TB. So if you remember, there are 4 things: cough, weight loss, night sweats, and fever, which are some symptoms of active TB. Now, the radiological features of suggestive active pulmonary TB are a bit more complicated. We saw extensive presentation, but what I want to emphasize is some of these features cannot really differentiate between active TB and old TB, because when the lung is damaged, these changes tend to persist, especially things like cavitation. It is once you exclude active TB, it's a laboratory criteria that on which we diagnose latent TB infection. It is either a positive tuberculosis test or TST, or the form that we use in Sri Lanka is called a MAN2 test, or a positive interferon gamma release assay. Let's talk a bit about the interferon gamma release assays because I'm not really made any slides about them. Now, the important thing to remember is it's a blood test. Now, what the test does is it tests on live lymphocytes. They put some tuberculin proteins and see whether it releases interferon gamma. Now, the problem is we are sending blood. This is not done in the government sector as far as I know. And this is, we send samples and they collect the samples and do this test. So most of the time, the lymphocytes are actually dead by the time we do the test. So the interpretation of that needs to be, you need to be cautious when you interpret this test. Now, in other countries, they have an indicator for that in the test itself. But in the reports that we receive, we don't really have that indicator whether the cells are alive or not. But there are places where interferon gamma release assays are more important, such as when you are immunocompromised. So they are more sensitive in that context. And also, patient does not have to come back for a reading. So it's you do the test, take the blood, and you can get the result. But for tuberculin skin test or MAN2 test, you have to do the test, and the patient have to come on the date that it has to be read. On that particular date, if they don't come, so the patient has to visit 2 times for the test. So there are advantages and disadvantages. So if you take the pediatric population, I think you want to avoid the blood test, so you might want to do a MAN2 test instead. Now, there are, let me emphasize again, the MAN2 test is not done to diagnose active pulmonary TB. It's mainly done to diagnose latent TB. There are reasons for false positive reactions. So infection with non-tuberculous mycobacterium can make it false positive. Previous BCG vaccination, especially up to about age of 11, can make it false positive. Incorrect administration and incorrect interpretation of the reaction. Not only that, there can be false negative reactions. If you do this on a very weakened patient with a weakened immune system, such as severe malnourishment, HIV, and so on, you can get cutaneous allergy. Also, if you do it within, now we tend to, when we do the contact screening, we tend to do it very early, we rush and do it now. But the recommendation is if they have a very recent infection, it takes about 8 to 10 weeks to develop this MAN2 positivity. And on the elderly also, it can be negative. On the very young age, before 6 months, it can be negative. With some concomitant viral illnesses, measles, chickenpox, and live vaccinations, also it can make the TST negative. Incorrect TST administration and incorrect interpretation of the reaction. In addition, I noticed when I was working in the neuro area, that area, it was always negative. So it's not yet in this list. So neither the TST or IGRA can use to diagnose active TB. So now this is an area that I can improve it. Now, if you remember, all of us as government servants, when we have to do a government medical. So if you read that carefully, there is something called the MAN2 test there. And it is mandatory because it is there in that form. I don't think it can be filled without this mandatory test being done. We do the chest X-ray, it is there. If you read it, it is there. So we do the chest X-ray, but we don't do this MAN2 test. But especially, I believe, in the healthcare workers, we are not having an active TB screening program. So for those people, I think at least for those people, we should start implementing a TB screening program, and screening for latent TB is also part of that. Now the groups that have been emphasized in our guideline, who should be tested for latent TB, are people living with HIV and also HIV negative or close contacts of a patient with pulmonary TB, and also other HIV negative at-risk groups. So basically, all people living with HIV should be screened for latent TB after excluding active TB. Now also, all children living with HIV who have successfully completed treatment for TB disease will be evaluated for reactivation on a monthly basis at or each encounter with a healthcare worker. Now for those with HIV, first step is to, if you remember those 4 symptoms, and the chest X-ray to rule out active TB. And tuberculosis skin test or IGRA, or IGRA is better, can be done to evaluate for latent TB. Now, if the tuberculosis skin test is done, cutoff is different. The MAN2 cutoff we use for other people who are HIV negative is 10. For HIV positive patients, if the induration is more than 5 millimeters, we take it as positive. Now, it is vitally important to document the induration in millimeters rather than saying whether it's positive or negative. For those close contacts with a patient with pulmonary TB, infants and children, basically everybody who is a close contact of a person with pulmonary TB should be screened. Now, this specially applied. I think we recently had a teacher. I think the whole class should be screened, and selected high-risk household contacts of patients with multi-drug resistant tuberculosis should also be screened. Now, the problem with MDR-TB is, by definition, they are resistant to INH and rifampicin. So, if we diagnose latent TB among those close contacts, actually, we don't have a regime to give in our setting in Kandy. When to do TST on a close contact? Any answers? We discussed that. When would you do? Huh? Yes. So generally, if the patient is sputum positive, we should wait until the patient is sputum negative, and after that wait for 10 weeks, because you can infect the close contact on the last day, no? Theoretically. So after 10 weeks of spear negativity, we should do. So that is the recommendation. But unfortunately, we tend to do it rather early, which probably gives a lot of false negative results. So out of the other HIV negative at-risk groups, I think one important group are the prisoners, and I discussed about healthcare workers and immigrants from high TB burden countries, and people who are using illicit drugs may be considered based on local research evidence, individualized risk assessment, and sound clinical judgment by experts. We are already doing patient latent TB testing on patients who have been initiated on anti-TNF treatment. And the other group that we should concentrate is on the patients who are on dialysis or are having chronic kidney disease, and also preparing for solid organ transplant or hematopoietic stem cell transplantation, and also patients with silicosis because they are more at high risk. Now, the recommendation is that we should, consider our available resources and prioritize before we set up, broad-based recommendations for these groups. Now, the question that I have been told to discuss is whether to treat or not to treat latent TB. Now, one important thing I think is patient autonomy. Can people with latent TB refuse treatment? Can patients with people with latent TB? Anybody says yes? Hands up, please. Only two. Good. Anybody say no? Hands up. No. So yes wins. So I think that is correct. You see, this our Quarantine Act of 1953, is it? Covers tuberculosis, and I believe that only applies for open or transmissible cases of pulmonary TB, because those are the population who would put the other people at risk. Now, people with latent TB are not infections, so therefore we can't force some treatment upon them. And the other thing that we already discussed are the risk of developing active TB. So the previous groups that we discussed, the high risk groups that can go on to develop active TB, and also the first 2 years after the initial exposure is the time period where we should treat, because afterwards the risk becomes lesser. And also when it comes to risk others, so especially when it comes to the healthcare workers, because if we infect another patient, for example, if we infect immunocompromised patient in the hospital through a healthcare staff, we are liable. As an institution, we are liable. Therefore, they are a group of people we should be thinking about treating and screening. And also, we should not forget about the risk of developing drug-related side effects. So these drugs that we use can have various side effects and interactions. So there is generally a discussion of that with the patient, and also individualizing the treatment decisions based on this. And lastly but not least, how sure are you that there is no active TB? Now, if you are not really sure whether if you are not sure in the spectrum, sometimes we tend to treat for active TB rather than treating for latent TB, which might give rise to drug resistance. So there are basically only two treatment options available in Sri Lanka. We can give INH alone or INH plus rifampicin. The doses are clearly mentioned. But I think we should also consider rifampicin only treatment for patients with initial high aminotransferases levels. So just some of my thoughts about the future. I think compliance, now we are going to treat asymptomatic people. So we are going to treat them at least for 9 months or 3 months with a drug that with potential side effects. And also, we are going to emphasize on compliance. So for these reasons, I think depot injections may be the future. I think people have already been doing research on this. I think they will come in the recent future. But the problem with depot injections is that once you inject them, they are not removable. So the next step would be thinking about drug releasing implants, which if they develop hepatotoxicity, we can remove the implant. So that's what I want to discuss about latent TB, and I think I'm well within time.